Good evening, everyone. First of all, I would like to thank Vitull sir for providing me this opportunity to present at this prestigious platform of MAPICON. So, my topic of talk today is paraxia of unknown origin, also known as fever of unknown origin. First of all, coming to the definition. Now, it is defined as a temperature of 101 degree Fahrenheit or 38.3 degrees centigrade or higher with a minimum duration of 3 weeks without an established diagnosis after an intensive 1 week investigation in the hospital. Now, nowadays, there has been a slight change in the definition. That is, the 1 week inpatient investigation is no longer required. So, we will be describing the workup, we will be outlining the causes, summarizing the treatment, and we will review the importance of improving care coordination among the interprofessional members to improve the outcome for patients. The causes of fever of unknown origin are often the common conditions which are presenting atypically, and the list is extensive, that is around more than 200 causes. Broadly, we will be classifying it into 4 categories. That is, the infections, then non-infectious inflammatory conditions, followed by malignancies, and lastly, but not least, the miscellaneous causes. Now, out of these, the infection is the most common cause, comprising around 40%, followed by malignancy, that is 25%, autoimmune diseases constituting 15%, miscellaneous 10%, and there are around 10 to 15% of the cases of FEO which remains undiagnosed. Among the infectious causes, we have the tuberculosis, extrapulmonary tuberculosis, brucellosis, HIV infection, abdominopelvic abscesses, cat's crash disease. We have viruses like the cytomegalovirus, Epstein-Barr virus, toxoplasmosis, enteric fever. We can further classify it into organ-based infectious causes, tick-borne infections, and regional infections. Now, organ-based, like there can be a subacute bacterial endocarditis, sinusitis, mastoiditis, parotitis, vascular graft infections, Whipple's disease, then tick-borne infections like babesiosis, anaplasmosis, tick-borne relapsing fevers, and in regional infections like we have leptospira, rat bite fever, louse-borne relapsing fever. Coming on to the non-infectious inflammatory causes, mostly these are the autoimmune causes like the giant cell arthritis, SLE, rheumatoid arthritis, gout, pseudogout, Behçet's disease, sarcoidosis, Felty syndrome, Takayasu, Kikuchi disease. These are all the non-infectious inflammatory causes. Third, we have the malignant and the neoplastic causes, which comprises of lymphoma, renal cell carcinoma. We have the myeloproliferative disorders. We have the carcinomas of breast, liver, pancreas, colon. There is an atrial myxoma. There can be a metastasis to the brain or liver, and we have the malignant histiocytosis. Then there are certain miscellaneous causes like the drug fever, thyroiditis, Crohn's disease, pulmonary embolism, hypothalamic syndrome, cyclic neutropenia. Then there is another term, that is the factitious fever. Then there is another classification, that is the Durek and the Streets classification, according to which we classify it into 4 different types. That is the classical, nosocomial, neutropenic, and PU associated with the HIV infection. Among the classical, the frequency of each category varies by both time and location. Endocarditis, complicated UTI, abscesses, and tuberculosis are the most common cause. In patients over the age of 65, the connective tissue diseases, these are to be determined the cause of fever more frequently. And fever in travelers is likely to be secondary to the infections such as malaria, typhoid, and acute HIV. Nosocomial, that is the healthcare associated fevers, which can be due to the drug fevers, due to complications post-operatively, venous thromboembolic diseases, malignancy, post-transfusion reactions, and the Clostridium difficile infections. Then neutropenic fevers are common in this subclass, and they're most frequently due to the infections. HIV-related FPO, the fevers can be present during the acute illness. These are common in the setting of untreated infection, and there is additional infection with the opportunistic organisms. Now coming on to the history and the physical examination. There is no clear-cut diagnostic approach, and the key to pinpoint the origin of FU is the thorough history with a focus on the most probable etiology based on the patient's symptoms. The important aspects of history includes the family history, immunization history, dentition history, occupational history, nutrition and weight history, drug history, that is the use of over-the-counter medications or illicit drug abuse, sexual history, recreational habits, animal contacts, and history of any surgery, trauma, or any of the procedures. Now, the most important clue which can give us is the fever patterns. As per the fever patterns, we have three, that is the intermittent, continuous, and the remittent fever. Intermittent fever means any fever which is characterized by intervals of normal temperature. Continuous fever means temperature remains above normal throughout the day and does not fluctuate more than 1 degree Celsius in 24 hours. Then we have the remittent fever, that is the fever pattern in which the temperature varies during each 24-hour period but never reaches normal. Certain other fever patterns, like there can be a tertian or quartan fever in malaria, undulant fever, brucellosis, tick-borne relapsing fever, borreliosis, palabstine fever, Hodgkin's disease, periodic fevers in case of cyclic neutropenia, and double quotidian fever in adults' disease, malaria, and typhoid. So first of all, coming to the infectious causes, what history and physical examination is important in infectious causes? There is a history of any prior invasive procedures or surgery, history of exposure to the tuberculosis patient, pet contacts, mosquito or tick bites, rodent exposure, history of any blood transfusion, and history of use of immunosuppressive drugs. If there is a history of exposure to unpasteurized dairy products, then it gives us a clue in favor of brucellosis, Kaur fever, and Yersinia infection. If the patient has a contact to birds, then there is a more likely infection of chlamydia, psittaci. Exposure to cats gives us a clue towards the toxoplasmosis or a cat scratch disease. HIV and disseminated gonorrhea in travelers and sexual encounters without barrier precautions, and acute Epstein-Barr virus infection should be suspected in the daycare centers as it spreads very easily. Now, in cases of malignancy, there can be a history, patient gives us a history of malignancy, history of any unintentional weight loss. As per that, we must go for an age-appropriate cancer screening. There can be a history of family history of malignancy or history of any alcohol use or smoking. Then there are certain physical examination points which can give us a clue towards the malignancy, like there is a relative bradycardia with a long-standing history, it goes in favor of lymphoma or central nervous system malignancy. If there is a new heart murmur, we can go towards the atrial myxoma. Sternal tenderness gives us a clue towards the myeloproliferative disorders, and even an isolated hepatomegaly with FUO can give an evidence of hepatoma or liver metastasis. Coming on to the non-infectious causes. Now, important point to remember is that rheumatological etiology is less likely if a patient reports symptoms of rigors and chills. It goes more in favor of the infectious causes. So, collagen vascular and autoimmune diseases can manifest as FUO even before the presentation of muscle and joint pain or stiffness or oral ulcers. The fever distribution analysis should be done in these patients, like if there are morning fevers, it goes more in favor of periarteritis nodosa, whereas if there is a double quotidian, it goes more in favor of the adult Still's disease. Now coming on to the investigations, we will be dividing it into the non-invasive and the invasive part. Earlier we used to have 4 stages, stage 1, 2, 3 and 4, but now we will be dividing it to non-invasive and invasive. In non-invasive we have all the routine basic investigations like the complete blood count with differentials, complete metabolic panel, urine analysis with urine culture sensitivity, blood culture sensitivity, preferably 3 sets of blood cultures should be sent, chest X-ray, inflammatory markers such as CRP, ESR, LDH, creatine phosphokinase, then autoimmune markers like ANA, rheumatoid factor. We can go for a cytomegalovirus, IgM or PCR, then tuberculin or Monton test, IGRA, HIV immunoassay, CT scan of the abdomen and chest, and last we can go for a cardiac echocardiography if we are suspecting a atrial myxoma or there is a culture negative endocarditis. Now coming on to the invasive test. Now invasive tests are to be performed as per the differentials, and the most common are the bone marrow biopsies, biopsy from the liver, epididymal nodule or temporal artery, which can give us a clue towards any malignancy, infection, myeloproliferative disorders or the other inflammatory conditions. Then we can go for an upper GI or a lower GI and retrograde cholangiography as per the involvement of the GI tract. And then third, we have the nuclear medicine test. Earlier, the nuclear medicine tests were reserved for those patients in which the diagnosis was not confirmed even after the thorough initial evaluation. But now it has been seen that in certain European studies, they are saying that FDG PET or CT scan should be done at an early if we are not able to find a cause, because these are highly sensitive. It is a non-invasive technique and it can further guide us about the biopsy or aspiration. Then there are certain other studies like leukocyte labeled studies, gallium and indium labeled leukocyte studies. Now coming on to the treatment. Now no single standard FUO management protocol is present, but we should avoid the empiric antibiotics or the empiric glucocorticoid treatment if not necessary. But there are few exceptions. That is, we can start with the empiric antibiotic treatment or the empiric glucocorticoids if the patient has presented to us with a culture negative endocarditis, cryptic disseminated disease, temporal arteritis with suspected vision loss. Then there are certain specific examples like steroids have been mainstay of treatment in autoimmune diseases like giant cell arthritis, polymyalgia rheumatica. In case of drug fever, it is the best to discontinue the implicated drug, and we will be seeing that the patient is afebrile at least after 2 days of discontinuation of the drug. Then there is a naproxen test. I think nobody of us is very well aware of this. It's used to differentiate, that is, the infectious and the neoplastic etiologies. But this test is not specific enough to be useful for all the individual patients. Coming on to the prognosis, it has been seen that around 15% of the cases remain undiagnosed. Prognosis for patients with FUO is generally good. It will resolve spontaneously within weeks to months. In stable patients, for symptomatic management, we can go for the non-steroidal inflammatory drugs. Poor prognosis has been reported in elderly patients and those who have been diagnosed with a malignancy. And even in children who do not have a particular cause, eventually do better more as compared to the adults. Now, most important is the patient education. That is, patient is all the time very worrisome that why is the fever persistently coming and coming. So, the patients should work together with the providers by providing a thorough history to aid in the directed diagnostic testing. So the take-home message is that it is one of the most challenging diagnoses. It requires a thorough history, repeated physical examinations, and selective diagnostic testing. We must avoid a shotgun approach early in the diagnosis of FUO, and an interdisciplinary approach is important. Thank you.
Thank you, Dr. Amandeep. You have made this very complex problem a very simple, with beautifully explained flow how we should investigate the fever of unknown origin. Thank you very much.
Thank you.